Good morning, good afternoon, good evening, everyone. You're welcome to today's episode of Public Health in Real Life, a platform where we hope to highlight often neglected global health issues, celebrate unsung heroes from the field, and highlight the next generation of global health practitioners. There's a growing movement in the global health and development world called Decolonizing Global Health or Decolonizing Health in general. Whilst it has gained its origins in academia, it has slowly made its way on the field and to practitioners. So, in light of that, we will be hosting a series called the Decolonizing Global Health series. And today we would start with how we need to rethink program design and implementation. We have our guest, we're delighted to have our guest with us, Irene Atuhairwe, who is the Deputy Country Director of Seed Global Health in Uganda, where she's leading and providing oversight on the organization's efforts in strengthening health systems in Uganda through education, practice, and policy. You're welcome, Irene.
Thank you. It's a pleasure to be here.
We're delighted to have you as well. So, straight to the business of the day. We had mentioned earlier the term decolonizing global health. Can you describe what this term means and, from your perspective, where its origins have stemmed from?
Thank you so much. So I'm not going to give you a textbook definition, but I'll give you, from my own understanding and when I started hearing about this term, I would say that, you find that specifically I'm from Uganda and we had, we were colonized, we got our independence about 50 years ago. Other countries in Africa got, their independence a little bit earlier than us. But you find that after so many years of having finished colonization, most of the countries getting independence, the power dynamics, the structure of programs, the structure of partnership and collaborations between our governments still has that colonization. You find that we still have like looking up to the global north as the saviors. They have the power, they have the money, and all those dynamics filter through into program, into our education, into the way we do our things, into the way we dress. Somebody gave a good example that, we are all in Africa, but myself, I'm from an Anglophone country, and somebody from DRC, which is next to me, we cannot understand each other because they would speak French, I speak English, somebody else will speak Portuguese, maybe from Mozambique. So you find that all those effects of colonization still live up to today. And they also, filter through health and global health. You find that you have programs, partnerships structured and developed mainly from the boardroom by people who may not, much as they may be well-intentioned, they may not really understand the context, the cultural context of, the reality on ground. And all that will filter through the program. I have so many examples. Maybe I'll get some time to give some examples. But that is my understanding of colonization. It's still filtering through everything we do. And now the term decolonizing is trying to destabilize that structure, abolish those power dynamics. Of course, it's a long process. It's not something that we can do in one day. But I could say that, to be honest, I started hearing about this term in the era of COVID. I think COVID really highlighted the differences and the effects of colonization at a very big scale. You find that we had Ebola, because it was affecting most of the African countries, it affected Uganda, it affected Liberia. It didn't reach that global, didn't have that global impact. But with COVID, we've had a very global impact, and we've been able to see the dynamics of colonization. You find that something like vaccines, some of our countries could not be able to access vaccines, even when we had the funds to do that. But instead, countries were donating a specific type of vaccine to African countries. So COVID really highlighted all these power dynamics. And that is the time that, the conversation has really come up That's the time we've started having webinars and, discussing decolonizing, and people thinking about how do we destabilize this structure? How do we become, how do we ensure that our history, our culture, and the reality on ground really plays into our health and how we manage our health programs? So on the conversation may have started much earlier, but it has come to a large scale, and mainly because of COVID, because really COVID has highlighted these differences that we have in our countries and the impact of colonization. Yeah.
Thank
So
you
that's
for
from
that.
my understanding. Yeah,
Yeah,
thank
thank
you.
you for that expose, Irene. And it's interesting that you mentioned that COVID has really brought up, or highlighted, shed more light on those inequities that exist and that imbalance in power structures between the global north and the global south. And as we see it continue to play out, even in vaccine distribution and production and supply chain management. You have an interesting experience whereby you trained and practiced as a nurse, then you got an MPH, and now you have over 15 years experience in health programming with that focus on HIV, AIDS, maternal child health, health policy, and the likes. In your very vast and rich experience, can you elaborate on how, what challenges you faced or what successes you faced in program design from a low and middle income country perspective?
Thank you so much. So I would say that for a big part of my career, right from school, I mainly worked with HIV programs, which of course we know 20 years ago, really there was this new approach to partnership and global health, what we call the global health initiatives, mainly by most of the big programs are PEPFAR, Global Fund, and maybe other programs to fight malaria and so on. So I did work a lot in HIV programs, and I saw, the fact that these programs were designed to save lives. It was an emergency. They were designed to save lives. They had their own objectives. And also there was need for accountability and quick wins and also quick numbers. So I really saw the impact that such kind of programs can have. Where we were working, let's say, I'll give an example. I did supervise HIV programs in the western part of our country, working with hospitals, teaching them how to manage their programs, teaching them how to have programs to support patients to adhere to HIV medication. And you'd get into a hospital and find that, the HIV clinic is like a well-oiled machine. The drugs are there, the data is there, they are capturing the data, the health workers are there. And right about 5 minutes walk from the HIV clinic, you have maybe a clinic for malaria or for women, for antenatal. And they're like different hospitals altogether. You'd even wonder, is this really in the same hospital, even the same location? So such kind of programming where it's targeted towards achieving quick results, and it's more of a vertical program, really had some impact. I won't say like very negative impact, but it had an impact on the health system in general and also on the service delivery. You find that you have the drugs for HIV in the HIV clinic, and you don't have drugs for malaria in the malaria clinic or the outpatient clinic, or even something as basic as dewormers for children. They're not there, but the nearby clinic has everything. Or you look for data, say how many children have come into the hospital with malaria and so on, or how many have died in the first 24 hours, and you can't find that data. But when you go to the HIV clinic, everything is done right. So such kind of programming really brought up those disparities, where you have one focus on a particular disease, taking away the attention and resources, both human and money, from other priorities. Then the other challenge has been, I think now it has been a little bit solved because these are 20 years of experience, so we learn. But the other challenge was really moving away, being a little bit different from the national priorities, where of course we had the global priorities. We have to save lives, have to have how many people on HIV medication and so on, without considering what are the priorities of that country. What are the priorities at the national level? Things like prevention, things like, basically health education for other communicable diseases. There's, a paper I read where they were saying that services for some neglected communicable diseases were completely forgotten and everybody focused on HIV. So those are some of the challenges that we've seen. The other is sustainability, where you have, a program comes in 5 years. Most of the funding cycle is 5 years. Everything is done. I'll give an example. Let's say with maternal programs trying to reduce maternal mortality. You have funding 5 years, everything is done. Women are having vouchers, they can access hospitals, everything is in place to try and improve those indicators. And then 5 years end, the program ends, they write best practices, what needs to be done, recommendations, and so on. And 1 year down the road, we are back to square one, where all the gains that you would have got from such a program, if they were institutionalized into the health system, are lost, because this was a quick program meant to get quick results and demonstrate these results, and the system was kind of left behind. And at the end of the day, once this program ends, the system cannot catch up with what had been implemented before. The other challenge was leaving communities behind. I'll give an example. This is not in health, but I worked, for a certain organization which was bringing in volunteers of all fields. So there was this very, enthusiastic person who thought I should teach people how to use biogas, right? This is a great way of saving energy, conserving the environment, and so on. So a lot of funds were put in. They taught people how to make this gas and use it for cooking. Now, what they didn't realize that for us, most people, like in Uganda, they have not really appreciated the concept of biogas because it's from human waste. There is that feeling that, it's not clean. So a lot of funds were used to teach people, and at the end of the day, people couldn't use this very good method because of those cultural and perceptions. There are so many examples I can give. One is in HIV prevention. There is a part of Uganda which is a little bit left behind. It's not as progressive as the other parts. And the community is still traditional, they still wear their traditional outfits and so on. And in the beginning, the HIV rates were very low, the prevalence was low, but slowly but surely they started increasing. So people took programs for prevention, they took condoms, they took everything, and they didn't teach the community members how to use the condoms. They didn't even consider so many of their cultural aspects. And the stories that come out of that are very strange, because you see, like, some people were maybe wearing the condoms all day, others were not using them. These are people who don't even, like, they don't think it's necessary, like, to wear, like, food because of their climate. It's very hot. So you find that they use maybe like a lesu. So, and then now you're adding on something else. So they resisted the preventive methods that were being taken because the community was left behind. So those are some of the challenges that you find, that when you have such programs and you don't bring in the system, the national, the country, you don't consider what they can manage and what, they're willing to take on, where they have the capacity to take on. You leave them behind. Once the program ends, it's not sustainable. Then, of course, the community may not uptake the measures that you want to introduce. The other one is more on our side. It's really nobody's making, but our governments, because we have all this funding. There's been very little, from my perspective, contribution from our governments, and personally I believe that we can do better. We cannot really be expecting every time to be given, because this breeds dependency, and also perpetuates this colonialism that you're trying to say we need to move away from. So our governments have kind of relaxed, to my perspective, I think, because they know that there will be all these initiatives coming in, relaxed a little bit. And also it has breeded corruption, because we know that these programs are very quick. 5 years, everybody wants to make money out of this program before it ends. So you find that the money that gets to the beneficiary at the end of the day is a very small proportion of the overall funding that is there. So there are a number of challenges. I could speak all day, but those are some of the things I can highlight. Yeah, thank you.
Thank you, Irene. And you've definitely shed a lot of light on, like you said, the challenges. There's a myriad of challenges, but you talked about donor dependency, talked about sustainability. There's also this concept of the implementation gap where, the product and the outputs on paper do not necessarily translate to what happens on the field. There's this expression that says, he who plays the piper dictates the tune, which
Mhm.
kind of speaks to the donor dependency aspect of it. But I like that you also said there's some responsibility and onus that lies on in-country and local governments to also step up. Things like the Abuja Declaration and all those other
Mhm.
declarations that say you have to commit a certain percentage of your budget to health or certain percentage of your GDP to health. Are some of those measures that have been put in place, but we haven't necessarily seen the wins that we expect to see. But which you had alluded to, that change like this takes time, especially these kind of wide systemic and monumental changes. So historically, as you've said, international development and global health have largely been driven by North-South partnerships, as you know. So, with this call for more South South partnerships that happened long before even this term decolonizing global health and collaborations over the past several years, how do you think these have influenced program design and management, at least from your experience?
Yeah, just to elaborate a little bit, you reminded me of one point that I'd wanted to mention about the budget, the Abuja Declaration. You find that Uganda, in the beginning, we used to have about 8% of our national budget, 8 or 9% allocated to health. But as we speak now, the current is about 6%. So every year, you see that that proportion goes down. And while the donor proportion has been a bit consistent, about 60%, so because the government contribution goes down, you find that most Ugandans or most of the citizens would now contribute out of pocket. So a very big percentage of our health is contributed from, people contribute from their own pockets, because the donor contributions are really specific, maybe to HIV, to malaria, TB. So if you have any other disease and the government is not contributing, you end up paying for it out of pocket. So I think this really needs to change, and our governments need to step up. We cannot keep lamenting. We need to decolonize health without our governments making their contribution. So regarding South to South collaborations, I'll speak from my perspective again. I know on paper it may be different, but the collaborations I've seen that are South to South have been also funded by somebody from the global North, which is interesting that we have these collaborations, but at the end of the day, the person who is making it happen is is maybe from the global North. And of course, they will have their priorities, they'll have their objectives, they'll have things that they need to see, and we also need to account. So I find that even much as we have the South-South collaborations, we are still answering to someone. We are still making accountability to somebody else. But the beauty with this is that much as we are not, it's not, the collaborations are not based on funding, but we are able to share our experiences. We are able to, we know most of the contexts are similar. So we are able to learn from each other. This have been so much in academia, where universities are collaborating, South-South collaborations. They're able to share, for example, like in terms of COVID, how they managed to continue with education during this, during this time. And of course, the challenges are the same, internet and so on. We are able to learn from other countries. I think also the Africa CDC, and WHO Afro have also been very instrumental in trying to encourage these collaborations. And they've helped in experiential learning, learning from each other, understanding the context. But at the end of the day, as I mentioned, somebody's paying the money. And this person in most times is not from these countries. I don't know if you agree with me or not, but in many times it's somebody else who is, who sat in the boardroom. There's, you rightly mentioned, people sit in the boardroom, have these ideas, let's do this, let's do that, and then they'll bring the idea here. And we just implement the idea and have to account. So hoping that, with more of these collaborations, hopefully our governments or our countries are able also to put money and drive the agenda. If you don't put money, if you don't bring money to the table, you can't say that no, we are going to do something different. Yeah. So that would be my take on it. They are good for experience, but at the end of the day, we are still accounting to somebody who pays the money.
So there's definitely, I hear you and agree with you as it's still global north influence and funds and decisions. So there's this concept of the no-do gap in implementation science, and it just talks about people know what to do, but it doesn't necessarily translate to practices. So we had previously mentioned the Abuja Declaration, which happened decades ago. But then you've also highlighted that one of the impediments to true South-South collaborations or just rethinking program design and local ownership is a lack of funding, sometimes political will and drive from local governments. Or yes. So how do you think we can then truly achieve equitable partnerships between the global north and south if we still have these issues? How do we close that no-do gap?
Yeah, the first thing I would say is commitments from our governments. I think we cannot run away from that. We still, I may sound a bit political, but we cannot run away. You cannot come to the table with nothing and expect to drive the agenda. So that would be number one, to have that commitment from our governments to also contribute to some of these challenges. Then the other is to the recognition. I think, as I mentioned earlier, that some of these programs are well intentioned, the heart is in the right place, but things sometimes get away. So I think the recognition that there is this power dynamic is important, both from our perspective and also from the global north. And I think it has, we've had a lot of conversations, and when I speak with my colleagues, they do acknowledge that these dynamics still play. So that recognition, I think, is the first step, that these dynamics still play. Once you have the money, and once you're from the global north, you have a bigger say in what is going to happen. So once our colleagues are able to acknowledge this and educate themselves on some of the cultural context, and also ensure that there is, whenever you have a program, there needs to be somebody representing, because there is no way, like I would say, I tell people, there is no way I can know the context in the US without having lived there. So I'm not an expert. There's no way I can design a program that is going to help. Let's say I see on the news that there is a drug problem in the US, or a gun problem, right? We see this on the news all the time, but I cannot have the solutions because I don't know the context. So similarly, we have the solutions. There is a saying of African solutions for African challenges. Most of our leaders, political leaders, say this a lot, especially when it's going to benefit them. But it is true, because we do have the solutions. So having people who represent the community that you're going to serve is very important. And not only having them just for the sake of representation, but actually listening to what they have to say and putting those considerations into practice. If somebody tells you, if you come to me and say you're going to have a biogas production, company, I'll tell you it may not work, and you need to listen to that, because I know that you're going to have challenges. If there was a very good program, I think I will not mention the organization, but a really big, reputable organization about sexual education for young girls, young people generally. And we know that in our context, the family still plays a big role in sexual education. But this was kind of shifting it to the teachers. And a lot of money was put in, a curriculum was put in place, and it was not approved by the government. The religious leaders, challenged this, the parents challenged it. So you need to have people who represent that community to say this can work and this cannot work, and actually listen to them. And then the other is true partnership. I believe that all this, there is benefits, even much as we are the recipient of maybe a lot of funding, there's also benefits from on the global north side. There's something they learn from us, or there's something that they'll take away from these kind of initiatives. So appreciating that it's a partnership and not only a one, unidirectional kind of partnership helping the poor and so on. Even once we help the poor, there's something that will benefit, which may be a conversation for another day. So appreciating that it's a partnership and not really like unidirectional kind of service, I think also helps. But the steps, of course, we cannot run away from our own responsibility. I think for me, that would be the first step in the right direction.
Thank you for sharing that, Irene. And I do like that you keep stressing on ownership and local ownership and responsibility, and that not just asking for a seat at the table but bringing something to the table. Of course, you said this is definitely a topic for another day where we talk about that concept of reverse development or reverse innovation, but then still acknowledging where that knowledge and intellectual property stems from, which again is part of why this whole decolonizing thing started in mostly in academia, is local authorship, local ownership, and just local decision making also in program management and in health system strengthening. You did raise an interesting point earlier when you talked about vertical versus horizontal programming, and I believe some of it might stem from just the way health systems and programs are structured in the global north, and then bringing those solutions to the global south. What's your take on that?
Yeah, I'm doing a lot of reading on such programs. There's been a lot of studies done on the impact of having vertical programming. I think it was a good thing in the beginning because it was an emergency. And I'm not really saying that vertical programs are bad and they cannot they're useless. They have their own use in a certain situation, like in an emergency. But once you move out from emergency mode, there's the benefit of having that particular program embraced by the system, the entire system, and also making sure that it is equitable. The funding that is allocated to particular issues, let's say HIV, should not outweigh the funding that is allocated to maternal. Right now, speaking for Uganda, we have about 336 women per 100,000 live births dying to maternal causes. And you find that because of this, the literature shows that because of this vertical programming, a lot of attention was put on HIV, and this took away some services from maternal. So we have stagnated in that field. So I think once you get out of the emergency mode, we need to embrace that program needs to be embraced by the system, and making it a horizontal kind of approach where you strengthen the system to respond to all the problems that we have. One time is HIV, one time is COVID. Really, much as COVID has been devastating, and we've lost loved ones and friends to COVID, it's really highlighted so many things. One is the need to have a strong health system, because many times you had people who are wealthy leaving the country to go and get services elsewhere, but with COVID that was not possible. So the need for us to strengthen our systems, I think, couldn't be more highlighted. And I think with the vertical program, especially for HIV, because that's where my experience is in the first years of my career, they've learned, especially for PEPFAR, from these challenges. And over the last 5 years or so, a little bit more, they've tried to invest in health system strengthening. The way it's done may be a different discussion, but there's been that learning from the vertical programming now moving into health systems and the sustainability aspect. So I would say that we have learned, but all of us, the South, the North, there's been lessons learned and documented on, the benefits, the downside of vertical programming versus horizontal. And as we speak now, I think the move is more towards horizontal programming and strengthening health systems. And most initiatives have really tried to take this up. Yeah.
That's really great to hear that, and thank you for highlighting your experience in HIV. There are two things that just struck me as you were speaking now about COVID. I remember when COVID first started, we talked about it being the great leveler. So for people from, most of the sub-Saharan African countries who had funds and were used to traveling out for better services, couldn't travel. So everybody was facing the system. We called it the great leveler. Everybody was experiencing COVID, and then everybody had to be locked down. We're like, yes, COVID has shown that, it has leveled that we're all the same. But then as time passed, it then began to highlight the inequities, like we said earlier, in vaccine distribution, access to services, access to supplies. So it's interesting that it kind of like was a double-edged sword in that regard, which again speaks to just that whole, when we talk about collaborations and health equity, we really have to get to the root cause. So then you've talked about in sustainability, contextualizing solutions for the local needs, and making sure that health system strengthening is at the forefront of initiatives. But we had also previously said a lot of programs, especially vertical programs, were done because they were in emergencies, they needed quick wins. How do you think we can truly achieve true sustainability, true health system strengthening initiatives if those things are still going to take much time and people still need to get quick wins?
That's a that's a difficult question. I would say that I think again the solution really lies in ownership of our governments. I think without the ownership, much as so I mentioned earlier that the health system strengthening aspect also can be another discussion. Although programs have tried to put this in place, it's still you know mirrored off that vertical kind of program. I don't know whether you understand what I'm saying. So it's still mirrored off that vertical kind of program where there's funding to a particular organization, and then it's moving out in the field to strengthen systems and have health workers trained and so on. But without that true ownership, then it may not be it may have some gains, but it may not have long lasting gains. So until we take responsibility of our own health systems and our problems, and also putting equal contribution and equal will to solving our own problems, then we shall be in this for a long time. 10 years from now, 20 years from now, we may still be discussing the same thing. So really, I think the narrative needs to change, and it can only change if we, as the recipients, I'll speak mainly from the African side, equally contribute and respect like the declarations that we have agreed to, like the Abuja Declaration. I don't know any country that's really in Africa that still honors that declaration. I may be maybe off mark a little bit, but from my understanding, I don't think there is any that really honors that. And without that, there is no way we can have long-lasting solutions, because all these programs, at the end of the day, they need accountability. You cannot be giving money just anyhow. You need to account for it. You need to have results. And all those bring out certain challenges. So the only way we can solve it is if we take also some responsibility of our problems and try to solve them.
Yeah, and I definitely acknowledge that it was a difficult question, and thank you for answering that, because the truth has to be spoken when we have those conversations at the table. At this point, we want to take any audience questions before we begin to wrap up. I do see it's more or less a comment from Abel to Kamusima, but I think I will then try to spin it into a question where he says, "Thanks, Madam Irene. Public health in Rwanda is said to be somewhat average rated. So, as the Deputy Country Director for Seed Global Health, where you all are working to strengthen health systems, how would you say your work has been going on in Uganda, and what are your focus areas?"
Yeah, I would say Ebo is right, really. In terms of public health, where we're looking at the prevention aspect, I think Uganda has really done well, in preventing illnesses. In the prevention aspects, we have had a lot of experiences with not pandemics, epidemics, especially Ebola. And we always have like viral hemorrhagic fevers lurking around. So we have strong structures from the community, from the grassroots upwards. I think we've learned from our experiences, the bad experiences we've had, and strengthened those structures. But I think where the gap, I think, mainly comes at the tertiary level aspects of care. For example, if I got sick, if I got maybe God forbid, if maybe I got cancer, the kind of care that I would receive really leaves a lot to be desired. So I think from the public health aspects, we have done a lot of work. But when it comes to the tertiary care, I think we still have a lot of advocacy. I feel that health workers have been trained. Ugandan health workers, specifically speaking about Uganda, are relatively well trained. They have the skills, but when it comes to the system in place to make it conducive for them to deliver the utmost care, then there is a big gap. and it all comes from the investment of our government into the health system. So on our side, as Seed Global Health, we work in three different areas where we look at education, training health workers, but specifically in key areas like emergency care and maternal and neonatal child health. I think we have done well on that. Most of the health workers are now knowledgeable and skilled. Then it comes to the practice side. That's where the gaps start to come in. You have the knowledge, but what you have in place cannot allow you to practice adequately. So as a result, you kind of end up losing skills, and then you start improvising and doing things that may not be evidence based and so on. So there's the gap in there. And then on the policy side, we also have an aspect of policy where we are advocating, for strengthening health systems, but also having, the structures and policies in place to strengthen these health systems, mainly from governments. So I think we still have a lot of work to do. Something has been done. I can't say that it's all doom, but we still have a lot of work to do in the advocacy aspect, not only in Uganda but other countries where our ministries of health, ministries of finance really recognize that we need to invest in our own health systems. So that would be my answer. I think Ebo is right. Yeah. Public health, we have done a good job, but when it comes to the service delivery, health service delivery, there's a gap.
Yeah, definitely true. Highlighting all the different pillars of the health systems that have to work in synergy to bring the true results that we seek. So now we'll focus or like shed the light on you and your journey. So, what and who have been the biggest influence on your work in global health and program management?
I would say I think the big influence on my work, I think, started mainly, I would say a lot of my passion started mainly in the early years of my career, working in, PEPFAR funded programs, seeing what the gaps are. It's it's kind of wonder what I was away from. I would say that's
As we can see, we're experiencing some network interruptions. So we hope we'll be able to get Irene back soon. In the meantime, to any of our audience listening, please feel free to type in your comments, your questions, and we will get to them once our speaker is able to get back online. Welcome back,
Hello.
Irene.
Thank you. Those are some of the challenges
Exactly,
that we have
exactly.
in, working in this kind of environments. Yeah. Yeah, yeah. So I was saying, my earlier experiences really shaped, my current passion. Learning from that and appreciating the strength, and also appreciating what we could do better, really drives my passion. Then, of course, colleagues. My colleagues. I have a very close colleague of mine whom I worked with some years ago. She recognized the potential that I had, but I hadn't recognized it myself. And she encouraged me to apply for a certain job, which I could say really shaped where I am now. And I had not even thought about applying for such a job. And she told me, "No, Irene, you would be." I remember the word she used, "You'd be a stellar candidate." And she was from the global north. So my experiences don't mean that I'm saying everything, the global north is bad. So I really appreciate the strength from that side. So this colleague of mine identified me and encouraged me, and I would say that she, much as we are now in different paths, but I still appreciate that, and I know that I am where I am because she was able to identify that potential in me. So I have two major drives: one from my experiences and really having the zeal to strengthen our health system on the larger scale, and also a colleague of mine who has been able to appreciate what I can bring to the table and really push me beyond my comfort zone. Yeah.
Thank you for highlighting the power of coaching, mentorship, and sponsorship in one's career development. We do have an audience question that I want to take before we take the last question, and it's from Ayo Bamigbe Faloye. It says, Ma, what can you say about the same governments that we are clamoring to take charge of our healthcare system in terms of political will, ownership, financing, and budgeting, etc., when they are still granting licenses to tobacco, alcohol product, and alcohol products manufacturing companies? I know this is somewhat of a political question, but would you like to address that? Welcome back, Irene.
Thank you. Can you hear me now?
Yes, yes. And I don't know if you heard or can read the audience question.
I I am using my phone, so I now changed my phone, so the font is a little small. Let me try.
Yeah, but I can read it out to you. So it says, Ma, what can you say about the same governments that we are clamoring to take charge of our healthcare systems in terms of increased political will, ownership, financing, and budgeting, etc.? And these governments still granting licenses to tobacco and alcohol product manufacturing companies.
Um, yeah, I think that's really depends on the country. I know for Uganda, we have there's been a lot of discussions about that, and a bill was passed. I may not speak like in detail because that hasn't been my area, hasn't been an area I've, taken a lot of interest in studying. But some of these decisions are based on, so sometimes, can you hear me?
Yes, we can. You're breaking up a bit, but we can still hear you. Please go ahead. Please go ahead, Irene.
Hmm.
Welcome back,
I'm really
Irene.
struggling.
I
I'm really
know.
struggling with my internet. Can you hear me now?
Yes, I can.
Yeah,
I,
I
I
was
think
going to say that it varies from country to country. I know there was a lot of advocacy from public health specialists regarding the tobacco companies, and there was a bill actually passed, and some conditions were put in place regarding you know uh, tobacco companies. But I also appreciate the economics aspect of it, where we need to make money, and most of our economy is really based on agriculture. We have a large tobacco growers, they need to make money and so on. So all those were taken care of in the bill. And maybe, I don't know which country that was from, but each country really has different things they have to take in place and come up with their own laws regarding tobacco.
we appreciate that response. So the last question for the day before we wrap up is, what advice do you have for current and aspiring global health practitioners from specifically from low and middle income countries who wish to grow their expertise in key technical areas in global health, who want to lend their voices to the discussions on key global health issues in order to make an impact locally, nationally, and globally?
Thank you. So I would say one, of course, is the proverbial, work hard. Of course, I know sometimes it doesn't make a lot of sense because the hardest workers sometimes don't get, sometimes it doesn't play out like that. But you really ensuring that you understand and you research a lot, um, on the issues that you're dealing with, both on the national, regional, and global level. Make sure that you know what is the reality, and not only in your country but regionally and globally. And once you get that opportunity to speak, ensure that your voice is heard. Sometimes we keep saying we're not given, the voice, we're not given a seat at the table, and sometimes we give somebody a seat at the table, and they don't do anything with that opportunity they've been given. So utilizing those opportunities, um, and also ensuring that you represent your community in authenticity, being authentic and somebody who has integrity, and ensuring that you represent the community you're coming from well. It's not only opens doors for you, but also for others. Yeah. Sometimes, the generalizations are bad, but if somebody has had a bad experience with you, they may not give the opportunity to somebody else. So you need to ensure that you use that opportunity once you get it to the best of your ability. So those are the three things I would say. And also network, social networking. We cannot underscore, I cannot underscore that it's very, very important Don't burn bridges. Ensure that you work well with your colleagues and maintain the networks. You never know how you end up interacting with these different people at another avenue or opportunity.
Thank you so much, Irene. First of all, I would like to thank you for your flexibility and your resilience, like walking through the internet challenges and the network interruptions. We
Yeah,
we are
yeah.
definitely very grateful for your experience and expertise. To our audience, we say thank you. We thank you for shedding the light, being our first speaker in this decolonizing global health series, and walking us through that journey of the origins of that term, how COVID has really shed more light and elevated the conversation in decolonizing global health and those systemic and historical structures and power inequities that exist in global health and international development. We also really appreciate you talking about program management, specifically how to implement and manage programs and ensure that we have maximum impact, the concept of vertical versus horizontal programming. And I think most importantly, talking about the concept of accountability, local ownership, and responsibility in helping change the narrative. So, for any of our audience who is watching and would like to connect with you, because you mentioned the power of social networking, what are your social media handles and how can they reach you?
Yeah, you on LinkedIn, it would be, how my name is spelled out, Irene Atuhairwe, and then Twitter. My name is a bit complicated for those not in Uganda, but it is the first name Atuhairwe underscore Irene at Atuhairwe underscore Irene. Then Facebook, I'm not so active there. You know that Facebook has been banned in Uganda, so I need a VPN to access it. So I'm not active on that front, but on Twitter, you can find me there and follow me, and I'll also be able to interact with you. And LinkedIn, yeah, thank you.
Thank you, Irene. Once again, thank you so much for your time, for you just walking with us through all the challenges. Thank you to our audience. Please like and subscribe to our channel, and give us feedback on people you want us to elevate, unsung heroes from the field, people doing great work from low middle income countries and any area and in any field specifically. And we look forward to having you all. Thank you all once again. Stay safe and be well.